Now, in the last three lectures, we had seen the history taking, how we proceed in the history, that is, the presenting complaints, the analysis of the presenting complaints, and additional clues from different other components of the history. Now, in this lecture, we see how do we proceed with individual symptoms. The classical example is pain, and out of this, we are going to see chest pain today. Now, when we see pain, we have three different type of pains in the body. One is somatic pain, the other one is the visceral pain, and then we've got a psychosomatic pain. Now these all have different features. The somatic pain, in this, the pain is very sharply localized and patient can point that this is exactly the site of the pain, while the visceral pain, which is diffuse and ill-localized, patient actually cannot exactly pinpoint where the pain is, and the visceral pain may also have associated autonomic features. Somatic pain can also have autonomic features if the patient has severe pain. And then we got psychosomatic pain, which is very difficult to localize, and it's occasionally wandering. Patients cannot really describe. Sometimes patients say that it's here, others on other times this is here, but they do not give you a very clear anatomical localization of this pain. This pain is different from visceral pain in that it may not be associated with the autonomic outflow until and unless patient has severe psychological disturbances as well, which can be appreciated when you're taking the history and doing the examination. Now we see chest pain. When we examine chest pain, we see the location and radiation of the pain, we consider the onset, we see the severity of the pain, we see the character of the pain, what are the aggravating and relieving factors, and what are the associated phenomena with this, and how is the pain progressing. So we individually see all these features of the pain coming from the chest. Now see, location and radiation, it is very important. You see, there are central chest pains, they present in this area, and then we got pain on the sides which are called hemithoracic pains. So we can see what are the reasons for central chest pain. Central chest pains are mostly because of vessel abnormalities. For example, the pain may be cardiac. This pain may originate in the center, or it may sometimes be on the side, and the patients generally do not put a finger on their chest. They just say that there is something here, the pain is here. It may radiate to the arms, to the shoulder, to the throat, to the jaw, back of chest, that in the interscapular region, or it may radiate into the epigastrium as well. Similarly, the central origin pain may be because of the esophagus. Patients who got esophageal spasms or ulcers in the esophagus, they may have pain in the central region of the chest. This pain is quite similar to the pain in cardiac disease. Sometimes it's difficult to differentiate between these two. There may be additional feature which might be helpful in differentiating these two pains. It may radiate to the epigastrium, to the throat, or to the back of the chest. And then you've got aortic pain, which is quite a bit serious pain of aortic dissection, which is felt in the center and it may radiate towards the back. And then similarly we can have tracheal pain, which is central in origin. And then there may be mediastinal pain. Tracheal pain is one of the mediastinal pains, and then if there is a mass or problem in the mediastinum, we may have a central chest pain. And then some of the abdominal pains may be referred to the chest. For example, the pain of pancreatitis or pain of cholecystitis, or sometimes the pain of the peptic ulcer may radiate upward. But these are usually, for example, gallbladder pain is hemithoracic, it's generally not central, but pancreatic pain or peptic ulcer disease pain can be central. And then we have got hemithoracic pains which are present on either side of the thorax, either right or left. These pains usually arise from the parietal pleura. They usually radiate along the affected dermatomes of the chest. And then we can have the chest wall pains which can be localized, which can radiate, and they usually are present on sides. Some of the chest pains may be in the center, for example, just close to the center when there are the joints of the ribs with the sternum. They may be inflamed and the patient may have pain on close to the midline, but these pains generally do not cross the midline. They remain on one side. So the feature of hemithoracic pains is they do not cross the midlines, while the central pain, they do cross the midline. And then we can have neurological pain which are coming from the spine or the nerve. They may be felt on one side and they may radiate along the distribution of those nerves. And then we see onset. Certain onset pains generally are serious. One of the serious, most important sudden onset pain is pain of ischemic heart disease. Then pain of aortic dissection may be sudden. Pain of pulmonary embolism may be sudden. Patient may have pneumothorax which may present with sudden pain. Musculoskeletal or neurological pain sometimes may be sudden, sometimes may be slow onset, but they can be sudden. For example, if there is a fracture of a rib or there is a vertebral collapse, and because of this there is a nerve compression, that may be a sudden pain. And then we've got gradual or slow onset pains. The gradual or slow onset pains, there may be esophageal in origin, they may be pericardial, they may be pleural, or they may be mediastinal. So these pains generally develop over time and the relative speed is different. For example, pain of mediastinal tumors that is slowly growing, the pain gradually develops, while in esophageal or the pericardial pain, they may develop relatively more quickly. And then we assess the severity. Severity can be assessed on some pain scales. For example, we ask the patient how the patient can rate from 0 to 10, what is the severity of the pain. So we can use that severity scale. Severe pains are seen in ischemic heart disease, patients who've got myocardial infarction, patients who've got aortic regurgitation. Sometimes the diffuse esophageal spasm has severe pain. Pleuritic pain and neurological pain may be severe. The skeletal pain, particularly the pain of fractures of the rib, that may be severe in intensity. Otherwise, these pains are generally not very severe. They are mild to moderate in intensity. Esophageal pain, pericardial pain, abdominal pain, neurological pains, they may be mild to moderate in intensity, but the pain of myocardial infarction and aortic dissection and pulmonary embolism, they can generally be severe pains. And then we see character. Character is very important when you're assessing the pain. See, the cardiac pain has a typical crushing, compressing, suffocating nature. This differentiates this from many other pains. And patient just says that I feel that as if something has been put on my chest, and there may be sometimes patients say that I am feeling suffocated as somebody is just strangulating me. So this feature is seen usually in pain of ischemic heart disease. And then you got a tearing pain which may be seen in aortic dissection. Then you got pricking pain which may be neurological or musculoskeletal. Similarly, the stabbing pain can be seen in patients who've got pleuritic pain or patient who's got the pain from the musculoskeletal origin. And then we see aggravating and relieving factors. Most important is what is the relationship with exertion and rest. Pain which comes on exertion and improves with resting is pain of ischemic heart disease. And then if the pain is relieved with nitrates, most likely it's a pain of ischemic heart disease. Sometimes the pain of esophageal spasm can also be relieved with nitrates, because if there is spasm in the smooth muscles of the esophagus, there may be relief with nitrates. Then antacids, they relieve the pain of peptic ulcer disease, that is esophagitis and peptic ulcer. And then pain which are related with the breathing, they are pleuritic pain. Pleuritic pains are that they worsen with deep breathing or respiratory phenomena like coughing and sneezing, and they are hemithoracic as we already seen. So pleuritic pains and pains of musculoskeletal system, or even the neurological pain which vary with respiratory phenomena like coughing and sneezing, so they may be identified by their relationship with the respiration. And then skeletal pains, they just vary with the postures, so that may be important. And then associated phenomena. It is important that see what happens along with the pain. If the patient has autonomic features like nausea, vomiting. This is a visceral pain, usually seen in heart disease, but it may be seen in abdominal pathologies as well. And then if the patient has restlessness, apprehension, and anxiety, consider that this may be pain of ischemic heart disease, particularly if the patient has risk factors as well. And then shortness of breath and coughing, this may be seen in a patient who got heart failure or the patients who got respiratory diseases. It may be in the pneumothorax, it may be seen in patients who've got pneumonias or patients who've got ischemic heart disease with heart failure. They may have shortness of breath and cough. And then syncope, if the patient has syncopal attacks, it may be ischemic heart disease, it may be pulmonary embolism, it may be a massive pneumothorax that causes, and sometimes the aortic dissection, which may proceed into the posterior circulation, that is into the vertebral arteries, that may come up with syncope. And then patients who've got dyspepsia, the disease may be intra-abdominal, but sometimes patients with heart disease, they mimic dyspeptic symptoms, so you have to be careful. The patients who present with chest pain and dyspeptic symptoms, so rule out in particular ischemic heart disease. And then if the patient has fever, that means this is an infective process going on. It may be pneumonia, it may be pleurisy with effusion, or it may be an infection going on in the thoracic cavity like pericarditis. So this is important, that there is inflammation going on. And then skin rash. So you see the skin rash of herpes zoster presents with hemithoracic dermatopal pattern pain. So if there is a skin rash, possibility is that patient may have this sort of neurological pain. And then finally, patient, we see, are there any neurological phenomena with the pain? And then see the progression of the pain. What is the progression? Is the pain worsening? Is the pain static, or is the pain improving? So you assess for these, because the pain of angina worsens over time, and it, especially if it is an unstable angina, it remains there, it is static, and if there is myocardial infarction, it worsens. So if the pain has worsened, you may consider that the pathology is worsening. If the pain is static or improving, it means the pathology is improving. But you see, if the patient has myocardial infarction and then whole myocardium is dead, the pain may be gone as well. So you have to assess that this pain has gone because of disease improving or disease worsening. So all these should be considered when you are examining a patient with chest pain. And next time we will discuss another symptom in detail. Till then, goodbye.